Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Dr. Nick Colyvas from UCSF. Professor Colyvas is associated with the Department of Orthopedic Surgery at the University of California in San Francisco. Dr. Colyvas' main research and interest is in the field of meniscus preservation. Dr. Colyvas did his orthopedic residency and fellowship at the UCSF. He's board certified in both orthopedic surgery and orthopedic sports surgery. Dr. Colyvas is a member of the AOS, where he served on their practice management committee and continues to give talks and instructional lectures. Dr. Colyvas is also an active member of the AOSM and the COA, where he regularly delivers instructional lectures. So today it's my great honor to introduce you to Professor Nicholas Colyvas from UCSF. Over to you, Professor.
Thank you. Thank you to Professor Gopalan for the invitation to talk about one of my favorite topics here today, meniscus preservation, meniscus repair. And I will just jump right in here. So let's see, okay. So today we're going to talk about mostly the technical aspects of meniscus repair. Tips and techniques for getting it right the first time, meaning doing it properly so that you get good outcomes and happy patients. So I have no disclosures relevant to this talk. And when I talk about meniscus tears, I think that this quote really sort of underlines the fact that there's a lot of confusion, and I'm hoping that I can unlock some of the keys to making meniscus repair a successful part of your practice. So each year in the US, at least 750,000 knee scopes. Many of these are meniscus surgeries along with ACLs, oftentimes combined. And this is in the USA a cost of $4 billion. So globally, this is a massive burden on the healthcare system. So getting it right is important. And what are the keys to unlocking success in meniscus repair? Well, there's actually a lot of keys, but I'm often asked, what is the most important thing? What is sort of the master key to it all? And in my opinion, that is knowing when to operate, knowing which patient is the right patient with the right type of tear, and that you are going to use the right type of technique to get a successful repair, to get a good end result. So knowing when to operate is really the main key. But within that, there's a number of different other things. We definitely, number one, want to know when to operate. We want to know which type of tears need surgery. So you have to know all the types of tears. And it's pretty straightforward for some of those tears, the bucket handle tears, the flap tears, the root tears. Most of those are going to need surgery, not all of them. But you have to sort of know which type of tears. So you have to understand what your tears are. A vertical tear is very different to a radial tear, is very different to a horizontal cleavage tear or a flap tear. And so, you know, we all need to understand that meniscus tears come in all different types, and each of them has a different treatment program, both surgical and non-surgical. And when you talk to the surgical, which we're focusing on today, you have to actually have a very good understanding of what that surgery involves. You have to understand the blood supply, the concept of the red zone and the red-white zone. Steve Arnosky's wonderful slide always comes to mind when you see this. The penetration of the vascularity into the meniscus is not very good. So you have to understand that blood supply is key to healing. You have to understand the history. You have to take a good history from the patient, determine whether these tears are stable or unstable, and knowing the difference between that, whether they're acute or chronic, or sometimes some are acute on chronic, and whether these tears are degenerative or traumatic. And of course, the meniscus exists in the knee exists in the human. You can't just separate out the meniscus and say, I'm just going to treat the meniscus. It's all part of a big complex system. You have to know all the associated factors. Of all of these, probably knee alignment and knee stability are the most important. The others are definitely of some importance or relative importance. And, you know, if you don't have good knee alignment or good knee stability or favorable knee alignment and stability, you know, you need to do that ACL reconstruction or that HTO, whatever you need to get that favorable, those factors favorable. You have to understand the literature if you're going to talk to your patients. You know, you're going to want to know, they're going to want to know what your failure rates are. This is from Nepal's work in 2012, about 23% failure rate. Unfortunately, 10 years later, looked at this again, and you know, under 20, and maybe for sort of the newer devices and the newer techniques, that's less. But that's the reality we deal with meniscus repair. You have to understand the limitations too. So, you know, this type of tear, a flap tear that's tucked under the meniscus and is sort of rounded over and is chronic, this is not a repair candidate. You have to determine that sometimes at surgery, but oftentimes before surgery you can do that. And when you do that, you know, you do the appropriate treatment, which is resecting the meniscus. Let's get moving on here. Very important, you have to know the risks. Many of the devices we use, many of the techniques we use involve instruments that sometimes will go beyond your visual field, right? With the all inside ones, where you're actually deploying that anchor is out of your visual field. You don't see it. So you have to know your safe zones. You have to know your anatomy. It can be very helpful to have your axial MRI up in front of you when you're looking at these things and doing surgery. So it's very, very key to know the risks as we go through sort of this basic program. And then with meniscus repair, we have a specialized set of tools, and they're very different. So you have to actually know the complete set. You can't just know one set of tools. You can't just have one mallet and not have a spanner. You have to have the complete set of tools, and you have to know how to use them well. You have to know what their limitations are and what their what their capabilities are. So let's go into some repair techniques now. And if we talk about repair, if we go back to what's called the gold standard, and I think this still remains either the gold standard or a very effective way of repairing meniscus. It's the inside eye technique described by Henning, described by Noyes. And essentially you're passing a suture from inside the tear to outside of the tear, crossing the tear, and then tying it back over the capsule. You can use these type of instruments or these zone-specific instruments, and these are very effective in making repairs. Of course, with this type of repair, you do have to make another incision. You do have to go outside the knee, either medially or laterally. So you have to understand the anatomy. You have to understand where the neurovascular structures are when you do this. And it is somewhat of a technical procedure. So the inside-out technique is an excellent way of securing a meniscus, particularly posterior or posterior medial or posterolateral. It does require an open incision. You oftentimes need another assistant there to help you. It definitely takes longer than the other types of procedures, and there are risks of needle sticks as well as neurovascular injury. So it's absolutely key to know how to do this and to know how to do it well. Just from a historical point of view, to get around some of these, the stingers and the darts were invented. These were terrible. I'm very happy to see that they've now disappeared for the most part. And really sort of the all-inside technique that's been around for the last 15, 20 years, that is probably the most popular way meniscus is repaired, are these all-inside implant style techniques where two pledgets or implants are placed across the meniscus tear into the posterior aspect of the knee, and then there's a self-tightening or self-tensioning suture device. There's multiple different versions. You need to be comfortable with the ones you like and have a reason why you like that one over another one, and be very comfortable with how they work and how they don't work. And how they don't work is in a number of ways. So you have to be aware of the problems with these. First of all, in order to deliver that pledget into the back of the knee, it's quite a large implant. So you're going to make large holes. Those holes in a meniscus tissue that might be friable, that might be less than ideal, are really going to just basically give you one shot. And the other thing about these devices is they don't give you a precisely anatomic reduction. That reduction on a triangular structure onto a flat surface tends to sort of flip up that meniscus and open a gap inferiorly if you put one superiorly, and give you this sort of puckered look, which is a non-anatomic repair. So if you're going to use these devices, be sure that you double stack, and in other words, put a layer below them as well. Also, the pledgets are in the back there, and they're up against the neurovascular structures. And also, if this device fails, you have a hard plastic piece that's now floating around your joint, damaging the cartilage. So these are big concerns, including the concern that we had about the neurovascular structure that I showed you before. So in order to try and circumvent some of these problems, circumferential suturing has been around for about 10 years using multiple different types of devices. You can now actually take a suture and place it in place without implants, more like we would do normal suturing of soft tissues. And that's allowing us to address a little bit more like radial tears, horizontal cleavage tears, and flaps and complex tears. And these work by basically placing a box suture or a mattress suture around the tear and compression, which is anatomic. For horizontal cleavage tears, you can do the same sort of thing. For radial tears, you can do the same sort of thing. At the popliteus hiatus, there's some advantage there because you just don't have to go into the popliteus itself. You can secure the meniscus that way. So we'll talk about and show some of those. The other very important technique to know about is the outside-in technique. Here you're passing your spinal needle or specially designed needle from the outside in, and then retrieving your sutures that way and tying them over. These are very helpful anteriorly, where it's hard to get your scope instruments to look, get your portals correct to look at that. So you can switch to one of these techniques if you're doing anterior tears. And sometimes I'll use this posteriorly. Again, you have to be familiar and comfortable with it to say, hey, wait, something's not working. Let me switch to this. So, I mean, I think I've said it enough, but I'll say it one more time here, that you really have to be good at all of the techniques if you're going to be a meniscus surgeon. You can't just say, this is the technique I use, and then try and apply it to all the tears. You want to have all the techniques and apply them to all the tears. The other sort of additional technical tips, I think probably the most helpful, is the MCL pie crusting. This has been around now for 10 years. It's been shown to be very safe, and it's very effective. And I think at this point in time, any medial meniscal work that you're going to do is almost always going to require or be assisted by doing an MCL, a controlled MCL release, lengthening, however you want to call it, pie crusting. That'll open up that space, give you the visualization you need, give you the access for the instruments, and also help prevent damage to the cartilage when you do that. And this is the kind of picture you can get. This is a root tear, wide open. You can easily get your instruments in and out there. This is a bucket handle tear, and we're actually looking at the back. The bucket handle is actually in front of you, and it just shows you how well you can see the back and prepare it for your repair. So let's do some examples as a way of sort of going through all of the different ways to do this and all the tips and tricks. So the repair technique is obviously going to be dependent on your type of tear. And I'm going to go through a list of different types of tears and the different ways to sort of repair them with examples here. And I'll talk through how we do this to give you the best sort of tips and tricks, at least in my practice, of how I repair these. And again, we are repairing tears that we've determined clinically really should be repaired. You've got to have that first step first. But once you get to the surgery part, you want to be as technically good as you can. So bucket handle tears are very frequent in my practice. I think they're amongst the most common tears you're going to find. And they really have to be repaired properly. And so in my practice, what we do is, this is an example of an all inside, the most common way we do it. We check the tear. I always check the root very carefully. And then I'll pie crust the MCL so I get good visualization. Now I can see all the way to the back. I can get a shaver in there and really get a really good preparation. Now, when you're putting in the all-inside devices, they have an angle to them, and you can use that angle to help bring up that meniscus and get it anatomic, because otherwise that meniscus will want to flip down. The other thing you can do, that condyle will get in your way often, you can move to the side, get that needle tip above the meniscus into the capsule there, and then slide it back down and get that in there. And you always want to try put vertical sutures in. Horizontal sutures don't work as well. Once you've done that, it flips up the meniscus like we described. And so you put in a double stack, in other words, another suture below, and that'll bring your meniscus down back into position anatomically. Again, you can use the device. You can see sometimes you don't have a lot of real estate to work with there. And so that's why it's important to get this right the first time. Once you get that in there, again, the meniscus lifts up like that. So you double stack again by putting one below. And that will give you a really nice anatomic picture with that meniscus repair back in place there. The other thing to be that's important with these tears is to get the apical tear, the suture at the apex there. That'll help prevent this tear propagating under stress. And then your final always nice when you see a little blood flash there. Your final construct looks like this, double stacked up and down layer that's very solid. And this is an example of another bucket handle tear of mine that repaired in a very similar manner. So here's the unstable tear. We put it back. Then we placed 3 or 4 sutures on top. This is another suture at the bottom to get that anatomic repair. And that's what the final looks like. And in this case, we were able to go back 3 months later and take a look at it because this patient developed arthrofibrosis. We needed to do a lysis of adhesion. And here's your meniscus. It's solidly repaired. You can see the sutures have synovialized. You don't really see them anymore. And this thing's as solid as you get. It's solidly healed back to that well-prepared surface where it was anatomically reduced to. So you can get excellent results if you do this technique really well. What about complex tears? We all run into tears where we look at it and we say, wow, this thing's crazy. And some of them, again, in the right patient, with some of the newer techniques like the circumferential suturing, you can actually slowly but surely stitch this together. This requires a fair amount of meticulous work. One of the tips here is always use a passport type cannula, something that allow you to get the sutures in and out without tissue bridges. Tissue bridges will really ruin your day. If you don't have them, this can go pretty quickly. And slowly but surely, you sort of piece this together and eventually get yourself a repaired meniscus. Now, it's not the world's most beautiful meniscus, but most of that meniscus volume has been maintained. And that patient's cartilage is now protected. This is another complex tear here. You can see this has a bucket handle component, has a flap component, has a horizontal cleavage component, and that type of tear won't respond typically to an all-inside device very well. So in this tear, we used circumferential suturing and one all-inside at the junction of the posterior horn and the mid-body, and this is what we, my apologies here. Sorry. Technical issue, sorry. This is what we end up with. If you look underneath, you can see that horizontal cleavage tear with a nice puckering there. So let's talk a little bit about horizontal cleavage tears now. You know, I think in the past, a tear like this one on the left, we would have said is a degenerative tear and you can't repair it. This is actually a post-op MRI of a repaired horizontal cleavage tear of my patient. So I think in the correct setting, these are now more and more repairable. I would say younger patients, obviously, older patients less so. But these tears, my preferred technique is to use a circumferential device, and that gives you a horizontal force. If you use an all-inside device and hay bale with those, it gives you more of a vertical force. I'm not sure they make a huge difference, but biomechanically, this makes more sense to me. And these tears, essentially, you're going to have your tear like this. You'll have prepped the surfaces. If you like, you can put some fibrin blood clot in between the surfaces there like a sandwich. And then slowly, one by one, you place these sutures, you tie them. It's important to try and tie the knot in the back of the suture so it gets out of the way. And you tie a series. How many do you put in there? More is better. I like to put them 0.3 to 0.5 centimeters, so 3 to 5 millimeters apart. I think when you get your probe in there, that gives you a nice closed sandwich, essentially. Those leaves are closed together, and you can close those pretty nicely again, like that. And again, try and get the knots at the back with your knot pusher. If you're a shoulder surgeon, you've probably tied a lot of knots. A lot of knee surgeons who haven't done shoulder aren't used to tying knots. You have to practice and get good at that. And you can use these techniques for pretty complex tears. This is a predominantly horizontal cleavage tear, but you can see it has a flap there. And the option could be to take out that flap, but I chose in this case to try and retain it. And so we start by, first of all, always preparing the surfaces, getting your biology maximal for your repair, and then placing your sutures. And in this case, we use the all-inside device to place a couple of hay bale sutures. Sorry, that's the circumferential device. And then the all-inside device to capture this flap and pull that back into position, and then secure that in place. Excuse me. Once it's secured in place, continue with the horizontal cleavage repair, essentially, and finish that off with as many sutures as you need. Again, if you think you need another suture, typically put one in. I think that's the sort of principle. These sutures synovialize. People always ask me about what happens. There's a synovial layer that grows over them if this thing heals. And that's your final product. Again, you've maintained as much meniscus tissue and meniscus volume as possible. And I think, and this patient went on to do really well. So you can repair these tears, but there's a limit. This is a tear that I repaired that ended up like this and failed. So I think we're finding the indications, but if you repair them well, and you should get good results. We've been getting good results. Let's move on to root tears. Excuse me. I think this is a very common tear we now repair. We've recognized the dangers of not repairing these tears. I think technically we've gotten good at them. We understand that not repairing these tears is equivalent to doing a total functional meniscectomy. And I think Dr. Leprade really sort of pioneered the method that most of us always use now, which is the transtibial technique. You've got to get good at drilling tunnels and using your guide to get the tunnel in the right place. I always back the tibial fixation up because I don't trust the button entirely, but some people use anchors, or you can even use a post. I think that just making sure that you get very secure fixation there is very important. Here's a sort of an outline of how I do these. So first of all, I'll take a look and make sure we have the tear we think we have. Always debride the tear. And once you have that, I always test mobility to make sure it can get back to the root, to get back to its anatomic root. And just check all parts of it. And then I've actually switched my technique a little bit, and I drill the tunnel first. This is an older video where we put the sutures in. I use 1.3 fiber tape that gets you a very secure fixation. We then do our drilling here, and with the drilling, that'll provide the socket. You could use a flip cutter there. I think that's a very elegant way of doing it, a little bit more expensive. And then with the socket, I always prepare the socket really, really well. Again, I think biology is very important for meniscus repairs. I think you've got to get the biology as right as you can. Once you've made a really nice socket there, right, really down to bone, as you can clearly see there, you're going to shuttle a suture through here. You'll see on some of my other videos, I've got a nice little way of shuttling sutures, and you'll pull that suture down, and that gives you a really nice solid root repair that way. The lateral side, pretty much the same. Lateral is, sorry about that. Lateral is a little bit more difficult to access. Your tibial spine gets in your way a little bit. But if you have a curved curette, you can make that socket really nice. And again, that'll give you this nice solid repair down. Now, there's a lot of discussion in root repairs now about centralization. I don't think we have all the answers about when to centralize, how important it is, how much better the outcomes are. But again, I think you need to be good at drilling tunnels and putting sutures and shuttling them down. If you're going to use this type of technique, you can do centralization using anchors from outside. We don't know which is the ideal scenario yet, but just be aware that I think this is going to be something that will be added to a lot of root repairs in the future, to be determined. Let's go on to radial tears. So radial tears are amongst the hardest ones to repair, or let's just say the ones that heal the least well, because of the circumferential forces that are placed on the meniscus with weight bearing, with axial weight bearing. The radial tear wants to split apart. Horizontal cleavage tears actually are under compression, but radial tears want to split apart. So we typically protect these patients a little bit more than others post-op. But the repair technique with our all-inside devices and our circumferential suturing is essentially placing sutures across that gap and tightening or tying them down to help. But as I said, that is not the world's strongest construct. So there are other ways of doing it. This is one of them. I'll show two different ways. This is a transtibial technique. Start out the same way as every other way, which is probing your tear, and then again preparing it as well as you can. And in this technique, you actually can drill a transtibial tunnel here. You use your guide, you drill your tunnel up here. After you've prepared that tear, you can see how it looks kind of wide there, but the tibial tunnel can be drilled. The shuttling technique I like is using the cannulated part of the drill and passing the suture up there, and then you just save yourself a step by getting that out as your shuttling suture. You can prepare that bed. The key part here is now taking a suture and passing it with your suture passing device. On the one side of the leaf, you've got to get a really good bite of that tissue, get through the good tissue. And then you take that same suture from the top and you come back in again. And in this case, you have to rotate the device upside down to get it to come from the top down through the bottom. And that will get you your transtibial suture. You could put one of these as an augment. You could put multiple of these sutures as an augment. In this case, I've used the suture here, and then we shuttle that down with the shuttling suture. Oh, apologies again. That's shuttle that down with the shuttling suture like this, and that gives you a really strong suture. Possibly the bone marrow from the tibial tunnel will also be adding to the biological effect here. You're then going to add your other suture repair here, put that all down, tighten everything up, and that's going to be your final repair. And then that is a very secure repair. It definitely will not move very much, which is a concern for the lateral side. So I tend to use this technique much more on the medial side than the lateral side. But that's a very secure repair, and that'll oftentimes go on to heal very well. More recently, I think the repair style or technique for radial tears that has become very popular and I think works very well is the rebar technique, where essentially you have two vertical arms. So this is an example of a medial meniscus posteriorly. Again, same thing, examine your tear, check for mobility, get your shaver and your spinal needle and your rasp in there and prepare the surfaces really well. Get back to fresh tissue. That's for every tear. And here what you do is you place a vertical arm on the one leaf on the one side. You will follow that with another vertical arm on the other side. So you will end up with two vertical arms like this. Again, in the best tissue you can find, a little distance. And here the first horizontal arm has already been put. This is the second one. One goes in again outside of that tear. So essentially what you're producing is a Mason Allen or ripstop type technique here, where your horizontal sutures actually have something to prevent them from pulling through the meniscus, which is the concern with those horizontal type tears. So this can be done very nicely with an all-inside device. This is sort of what the final product looks like at the end. You tighten it down, and that's a very secure fixation there. I added a centralization suture on this one here. This can also be done. This is from a colleague of mine. This video can be done with fibrin clot. I will talk a little bit about how I always use notch microfracture. This is now using PDS with an inside-out technique. So again, multiple different ways of doing things in meniscus repair. You just got to know your techniques and know what to do, how to do them well. Here the vertical arms are placed and the horizontal arms are being placed. Here comes the first one. And then the second one comes in here like that. And in this case, when the meniscus flips up a little bit, you can put one underneath as well. Here it goes. And these produce nice small holes as well, so you're not making big holes in your meniscus. So there's some real advantage there. And doing it this way, inside out, allows you to sort of tension everything together at the same time, so you can get maximal tensioning along that, or optimal tensioning along that. What about ramp lesions? Well, ramp lesions are important. You should see them, when you look at your MRI, you should suspect them when you have any ACL tear, and you want to be vigilant about these ramp lesions and what they look like, and understand what they are. Described a while ago, and I think their importance is only increasing now. And there's different types. You should probably know about these, but at the end of the day, you want to know if that ramp lesion is stable or unstable. And so the key to this is you've got to look. You've got to look every single time. You've got to look at the back of the knee, and you've got to look through a Gilchrist view, through the notch, and look at that, the back of the knee there. So you place your, and oftentimes you've done MCL pie crusting, and you're going to look in the back there. You're going to place your scope back there, and also place a probe in there. Don't just look there. You want to put a probe in there, and you want to look at the back of your knee. So I do this for every knee. This is a normal knee, no ramp lesion. But you can see how I've got the probe back there pushing and pulling, and just making sure that in this ACL that I don't have a ramp lesion. Even if I suspect it on the MRI or don't suspect it, I'm going to always look. The key is to always look. If you do have a ramp lesion, you want to repair it posteriorly. There's a discussion about back or forth, doing it from the front, doing it from the back. I tend to do most of my repairs from the front if I can be sure that I have a good reduction. If I don't, I come in the back. But with any meniscus or knee surgery, it's good to know how to do posterior medial portals. The way I do mine is I put in a spinal needle, and then I use a mosquito or a Kelly clamp, put that in there, and then spread wide. That opens up that posterior medial portal, and then you can put your cannula, you can put your portal device or cannula in there and do all your work from there. So that's the key to ramp lesions, is being very comfortable with getting the knee at 90 degrees to get all the structures to fall away, and then making that posterior medial portal. I also talked a little bit about anterior tears and using the outside in technique. This is an example of an anterior tear. This patient had an ACL reconstruction, and that tear, you can see, you first of all initially examine it. You can use the 70-degree scope if you have any concern. And here I am debriding part of it, and then using an outside needle here, feed in some PDS that you then capture. And in my case here, I've actually shuttled that PDS into a permanent suture, and then you just tie these again, and you get a series of nicely tied knots like this. Here's another one coming in, and you can come in. This is right at the root. And for these anterior tears, these are pretty rare, these anterolateral tears. But if you do feel that they are not quite as secure, you can check the stability. You can actually add an anchor to, once again, you've prepared the surface, you can add an anchor to really stabilize these. And that usually gives you a very nice result. But the key is, again, using an adequate number of sutures to fix that lateral meniscus. Not often symptomatic, but these work really nicely. Very happy patients if you get these right. So that's what it looks like with the outside-in technique. Again, got to know all your techniques, got to know how to do them all. Question I'm always asked, and is probably one of the keys to good results, is the rehab program. Every meeting, everybody has a different opinion about rehab protocols. I think that today in 2024, our radial tears and our root tears, those tears that want to extrude under weight-bearing load, should really have some level of protection. Whether that's 4 weeks, whether that's 6 weeks, whether that's 2 weeks is sort of an individual choice. I think other tears, we really need to move on to more accelerated weight bearing. There's nothing worse than an atrophied and stiff knee. No matter how good your surgery is, that's a hard problem to overcome at the end of the day. So I am now really fairly aggressively getting my bucket handles and my horizontal cleavage tears to weight bear quickly, within 2 weeks typically. But everyone has a different opinion on these. I think that's the reasonable approach with what we know today and with our improved techniques today. Everybody also asks me about biologics. I think this is very important. I think at this stage, every single meniscus repair gets microfracture at the notch. I think fibrin clot and PRP also have a valuable place. I don't use them in every case. Sometimes I use a combination of things. Sometimes patients will ask me specifically to use one or the other. I think you have to use something. The microfracture at the notch, I think, has good results and data behind it as far as we have, and is certainly very straightforward, easy, and inexpensive. And that's all I have for the moment. I'm happy to answer any questions regarding meniscus repair.
Thank you, Nick, for this wonderful presentation. Nick, you can stop sharing, actually.
Okay.
Thank you, Nick, for this beautiful presentation. Amazing scenarios, amazing technique. Let's have a short Q&A.
Sure.
Now, Nick, have you ended up in a situation where you had to do a partial meniscectomy? A meniscal balancing, that's what's the refined term. I'm sure you have not done in the last few years, but is there any situation where you have ended up doing that?
Yeah, so look, I think that happens. There's no question about it. It's the, you know, we cannot save all the menisci that come to us. I think there's a bit of a mindset, you know, if you go in with the idea that your goal is to try and repair this meniscus, that most times you're going to end up repairing it. But you also have to be you know, mindful that you're not really doing the patient any favor by technically putting back together something that's not going to heal. It may look good, it may make you feel good, but if it's, you know, if it's clearly beyond that point, now determining what that point is different for different surgeons. But I certainly come to that point. I did have one even last 2 weeks ago. And a young patient had a lateral meniscus tear that I had every intent on repairing. And when I got in there, it had been exploded. It had been, you know, part of it had clearly disintegrated. Part of that posterior horn was missing. I couldn't get the leaves to come together. It was just little bits and pieces of flaps, and just had to do a partial meniscectomy there. So I think that, you know, that still is, you know, a good surgery in the right setting. Like I showed the initial The first video I showed was that flap tear that had come out that had incarcerated in the gutter. You pull that out, you take that out. That is a very good surgery that works very well. Patient is very happy. You've still maintained a good amount of the meniscus. So I think there is, still very much a place for meniscectomy. Even within someone who's probably about as aggressive with meniscus repairs as possible. But I will say the key part to all of it is that discussion you've had with the patient and that they're on board with you saying, I'm going to be aggressive about repairing your tear. That's before you even get in there, you have to have had that discussion with the patient.
Thank you, Nick. And Nick, when we talk about bucket handle tear, right? So that is another situation where you find that, getting a repair sometimes is difficult. And the other issue is a 20% reoperation rate in some studies. Right. So what is your take on bucket handle tear? Are you able to repair them?
I'm almost always able to repair them. Even the chronic ones, the ones that are difficult are the ones that are chronic, and that bucket handle component has actually shortened. So when you push it back, it's almost like an elastic band or a spring that keeps coming back at you. Repairing that under tension probably is not going to work. But in general, a fresh bucket handle tear, and certainly a good number of the chronic ones, I think if you are meticulous about repairing them, and I think that's possibly why there's a fairly high failure rate. Two reasons. One is I don't think people put in enough sutures to really get it very secure. And I don't think they do enough anatomic reduction. 2 or 3 horizontal mattress sutures to put a bucket handle tear isn't probably not adequate. But assuming you've done that, you've done a really good repair. The other thing is a lot of bucket handle repairs, you've got to assess them for their stability, because some of them have some subtle instability, ACL instability or other instability issues. And I have actually done LETs on some of my bucket handle tears where I'm worried that, they're going to re-tear because basically you do a good job on their repair, but they have micro instability in their knee. And so, obviously, if it's an ACL problem, you revise their ACL to a good ACL. But in some, there's been that, occasional case where their ACL is okay, but they still feel a bit loose. I'll actually add an LET, for example. So it comes down to patient selection, but also sort of looking at all the factors again. That's, I think, part of what I discussed initially. The basic principle is look at the whole knee, look at the whole patient, then decide what you're going to do with the meniscus.
Thank you, Nick. Now, Nick, when you say that you're a meniscus surgeon, the save the meniscus is a quote, right? And so sometimes you may end up with people referring a meniscectomized knee or a partially meniscectomized knee, and someone wants to do a meniscal transplant, right? So interestingly, I hosted a surgeon from Rizzoli, the paper that you showed, Journal of Experimental Orthopedics, from Alberto Grassi and Stefano Zavagni,
Yeah.
their team. And they do a lot of meniscal transplants of late. And no, I just want your take on that, because when you say that you're a meniscus surgeon, I'm sure you're getting a lot of referrals to do a meniscal transplant, isn't it?
Yeah, I think that falls under the category of meniscus preservation, to be honest. And it is the case that I do get sent patients, or some of my patients even, who have had, previous meniscus surgery that has failed. I think that the common sort of saying with meniscus transplant is you're either there too early or you're there too late, right? So a lot of meniscus transplant, the principles are very much the same as repair. You've got to have good alignment. I'll often be doing an HTO along with my transplant. You've got to have stability. If you don't have a good ACL, or you've got a posterolateral corner, or whatever else, those things have to be fixed before you decide you're going to do a meniscus transplant. But probably the key one, of course, is how far it's gone, right? If your cartilage is beyond grade 2, I would say, I think grade 3 is a real gray zone for meniscus transplant. If it's gone beyond that, you probably are going to have to look at other options for your patient. But yes, as a meniscus surgeon, as someone who tries to repair meniscus a lot, I do get a lot of referrals for transplants, and also get a lot of referral for revision ACLs. Interesting. Meniscus and ACL dance together all day long. They are, I do 50% of my ACLs are revision ACLs because they've been sent to me for a meniscus problem, either deficiency or a repeat bucket or something like that. And you've got to revise the ACL at the same time. You can't just go, I'm going to go fix the meniscus and leave that knee unstable. You're going to fail. So that's sort of part of being a meniscus surgery, is actually being a ligament surgeon, an alignment surgeon, a cartilage surgeon. I do a fair amount of OCAs as well, Oates procedures as well, because you've got a pothole somewhere with your meniscus repair. You want to really optimize your outcomes. You put a plug in there as well. So that's part of what being a meniscus surgeon is about.
Thank you, Nick. Great. Nick, we also joined by Loy. Loy Al-Khatib is a pioneering orthopedic sports surgeon based in Dubai. Loy, welcome to the show, and your questions to Nick, please.
Hello, good morning, good afternoon, good evening. Hi, Nick. Finally, we met. Thanks a lot.
Absolutely.
Amazing talk, amazing tips and tricks for covering all the topics in meniscus. So 3 things to know, just to, again, on the message, look, feel, and move. When you go inside the knee, just need to identify that there's a meniscal tear. You need to know the pattern of this tear, and then the 3rd stage, how to fix it. Back to bucket handle tear, one of the chronic cases, especially chronic cases. So one of the advices for my colleagues is, don't force the reduction. If it's not reduced, try just gentle reduction. Otherwise, you will create a tear, most likely a radial tear, or will turn into disaster. So just try to shave it. Try to get the adhesion, because there will be neurovascularization between the meniscus and the ACL attachment or the anterior capsule. So take your time, release the adhesion, and gently reduce it. This is for the chronic bucket handle tear. I fixed a lot. This is one of the tips. Just if you try to force it to reduce it, and with a probe, you might end up with another tear. And good luck.
I couldn't agree more. I think that's great advice. Yeah.
Yeah, and regarding the outside-in technique, sorry, I'm not a fan of it. Outside-in technique there's a risk if you put the needle in, you push the meniscus out. So for me, it's hard to get the anatomical reduction. So I'm a fan of inside out, although it's really demanding technique, because you need really a good assistant, and then you need to catch the sutures from the other and then tie them. And all inside. The downside of all inside, all the devices are now, is that the tip of the needle is a bit thick. If the sleeve, once you go in, we make a big hole inside the meniscus itself when compared to inside out technique. So the other thing, I'm not sure if you agree with me, Nick, or not. When you repair a meniscus in cases of ACL deficient knees or ACL tear, would you go for the ACL and then repair the meniscus, or vice versa? So my theory is, go for the ACL, repair the ACL, so you have a congruent joint, especially in the bucket handle tear, you have a better reduction. What do you think about that?
I always go for the meniscus first. So this is great to have a discussion. I think that you can push and pull on that knee and open up that knee a little bit better in an ACL deficient knee. Maybe it's only a slight amount, but I don't worry about stressing or tensioning or detensioning my ACL by maneuvering my knee when I'm trying to do my meniscus, because I do put a fair amount of pressure and a fair amount of force across my knee when I'm doing my meniscus repair. And I think if you use the techniques that I showed earlier in my videos, you can get a perfectly anatomic repair of that meniscus. I think there is a risk of not being anatomic if the knee is not fully concentric, as you point out. But I think if you are very careful about how and where you put your sutures, you can definitely get a nice anatomic repair.
I agree. Awesome. Do you have any more questions?
Yeah, Nick. Nick, there's a question from the audience.
Yeah.
One, Dr. Leo Mercure. The question is, do you consider collagen matrix augmentation at the end of a complex repair case? to cover tear site from synovial fluid inflow?
Yeah, I think that's a great question. I think in the USA, so that's been pioneered in Europe, and actually was described by Henning 25 years ago using fascia lata. If you look back, you know, like so many things in orthopedics, nothing is really new. But there's a collagen matrix now that's under FDA trial in the USA. That's not freely available. I'm not sure exactly when that trial is expected to end. I think that's the next frontier for us for meniscus repair on a number of levels, either as augmenting the sort of complex tears and potentially as part of a segmental replacement for, you know, when you do a meniscectomy and you have a segmental loss. So a surgery, you know, a meniscus that's not really ideal for a full transplant. You could get a segmental piece in there that bridges it over. I think that sort of thing we're gonna find out in the next 5 or 10 years how effective that is. Certainly the data from Europe is looking promising, but we're not there yet in the USA. So I haven't done that. I have the collagen meniscus implant. Is something I've tried. I think that has very variable results. I don't use it anymore, but the wrapping technique, I think, has some potential benefits. The delivery of the wrap needs to be a bit slicker and easier. I think there's some instrumentation that's been devised for that now. So I'm looking at that space with open eyes here.
Thank you, Nick. Nick, I think that's all the questions that we have for the session. Thank you for this wonderful presentation and really look for more in the future.
Thank you for the opportunity. I always love to talk about meniscus, race cars, but you got me on probably the one I like the most. Thanks.
Awesome.
Thank you so much. Bye-bye.
Cheers.
Bye-bye.
Cheers. Bye-bye. Cheers.